We see high blood pressure all the time. It's one of the most common things we treat. But what if I told you that for a whole bunch of our patients, we're just chasing the numbers? That we might be missing a totally treatable, even curable underlying cause? Okay, let's dive into it, because today we're talking about primary aldosteronism, a huge and honestly super overlooked driver of hypertension. And really, this is the key question, right? It's what we should be asking ourselves way more often in clinic, because when you identify this condition, it can be a total game changer. It can fundamentally alter a patient's treatment plan and, more importantly, their entire long-term health. All right, so here's the game plan. We're going to hit 5 key things. First, we'll talk about why this is a bigger deal than just BP numbers. Then who you should be thinking about screening. Third, how you actually nail the diagnosis. Fourth, picking the right treatment, and we'll wrap it all up with the absolute must-know takeaways for your practice. So let's kick things off with part 1, aldosterone's hidden impact. And trust me, this goes way, way beyond what you see on the blood pressure cuff. So what exactly is this? Well, in primary aldosteronism, you can think of the adrenal glands as having gone, well, rogue. They're just pumping out way too much of this hormone, aldosterone, all on their own. And this is the critical part. It's happening completely independent of the renin-angiotensin system, the system that should be regulating it. That autonomy is the real heart of the problem. Now, this is where it gets really serious. The downstream damage from all this extra aldosterone is pretty nasty. It's not just about holding on to salt and water and jacking up the blood pressure. Nope. This stuff acts almost like a direct toxin on the cardiovascular system. We're talking direct inflammation and even fibrosis, scarring of organs. And get this, it leads to significantly higher rates of heart attacks, strokes, and death, even when you compare these patients to others with the exact same blood pressure. That is a huge deal. Okay, so knowing just how bad this can be, let's move into our second section, raising clinical suspicion. This is all about knowing when to start looking for it in the first place. And this brings us to the really practical question you're probably asking. We see so many patients with high blood pressure. Who actually needs this workup? Well, the good news is the guidelines give us some really clear answers. And this table basically lays it all out. These are the key groups to watch. You're looking for patients with severe hypertension, or what we call resistant hypertension. The person on 3 meds, including a diuretic, whose pressure is still not at goal. Or how about the person whose pressure is controlled, but it takes 4, 5, or even more meds? That's a red flag. Then you've got the classic combo of hypertension and low potassium. But don't stop there. You should also think about this in patients with an adrenal mass found by accident, those with sleep apnea, or anyone with a family history of really early onset hypertension or stroke. Okay, so let's say you have a patient who fits one of those descriptions. Your suspicion is high. What's next? That brings us to section 3, decoding the diagnosis. How do we actually prove it? Thankfully, the workup follows a pretty logical 3-step path. First, you screen for it with some initial blood tests. Second, you might need to do some confirmatory testing, just to be sure that aldosterone secretion is truly autonomous. And third, you do localization studies to find out exactly where it's coming from. That's what's going to guide the treatment. For that first screening step, this right here is the formula that matters most. The single best test we have is the ratio of the plasma aldosterone concentration, or PAC, to the plasma renin activity, PRA. A ratio over 20 plus an aldosterone level of at least 15, that's a positive screen, and that should definitely trigger the next step. I want to pause on this for a second because this is a massive clinical pearl. The old school teaching was always no low potassium, no primary aldo. Well, we now know that is just plain wrong. The truth is, most of these patients have totally normal potassium levels. So please, don't ever let a normal potassium talk you out of screening a patient you're suspicious about. But of course, there's always a wrench in the works, right? And it's usually this. What do you do about the patient's current blood pressure meds? Because they can absolutely interfere with the testing. So this table is your cheat sheet. For example, things like beta blockers, they suppress renin. That's going to artificially inflate the ratio and can give you a false positive. On the flip side, drugs like ACE inhibitors and ARBs, they can artificially lower the ratio and cause a false negative. Now, in a perfect world, you'd hold these meds before testing, but we don't live in a perfect world. So if you can't stop them, you just have to be really smart when you interpret the results. All right, so once you've confirmed the diagnosis with blood tests, it's time to find the source. You'll start with a CT of the adrenals, But remember, and this is a big but, a CT scan can miss small adenomas, and it can't tell you if a nodule it does see is actually the thing making all the aldosterone. That's why adrenal vein sampling is often the gold standard. It's the only way to prove for sure if one side is the culprit before you even think about surgery. And all of that detective work leads us right here to Section 4, choosing the right treatment, because the therapy is tailored directly to what you found in the workup. And here's why that localization is so important. The cause is really split between two main camps. About 60% of the time, both adrenal glands are overproducing. We call that bilateral hyperplasia. And about 35% of the time, it's a single one-sided tumor called an adenoma that's causing all the problems. And that difference leads you down two completely separate treatment pathways. Makes sense, right? If both glands are the problem, you can't take them both out. So the treatment is medical. You use aldosterone antagonists like spironolactone to block the hormone's effects. But if it's only coming from one gland, then you can go for a potential cure by surgically removing that one gland. So a few pearls for medical therapy. Spironolactone is kind of the workhorse. It's more potent, it's less expensive, but you gotta watch out for those anti-androgen side effects like gynecomastia. If those become a problem, eplerenone is a fantastic alternative with fewer side effects. And remember, the goal isn't just to lower the BP, it's to fully block the toxic effects of that excess aldosterone. And for surgery, it's incredibly effective for unilateral disease. It can actually lead to a complete cure of hypertension in a good chunk of patients. But here's a critical post-op tip. The adrenal gland you left behind has been suppressed for a long time, so you have to monitor for high potassium in the first month. And you actually tell the patient to eat a sodium-rich diet for a bit to help wake that sleepy gland up. Finally, let's bring it all home with the essential takeaways. If you remember nothing else from this, please remember these next 2 points. Takeaway number 1, think beyond hypokalemia. I'll say it again, most patients with primary aldosteronism have a normal potassium. Do not use a normal potassium level to rule this out. And takeaway number 2, the PAC to PAR ratio is your go-to screening test. Know the cutoffs, and just as importantly, always be mindful of how your patient's current meds might be affecting the result. I'll leave you with this final thought. Primary aldosteronism is not some rare bird. It's common, it's harmful, and most importantly, it's treatable. But the only way we can find it is if we look for it. So, how many cases of curable hypertension might you be missing?